Welcome to today's deep dive. So I want you to imagine going to a surgeon because you're having, well, a kind of plumbing issue. And to figure out what's wrong, their main diagnostic tool is to take a sterile, lubricated wooden cotton swab, insert it directly into the valve, and ask you to cough.
Right, which sounds, completely wild to most people today.
It really does. It sounds incredibly crude. But for decades, this really invasive, deeply uncomfortable maneuver was actually the undisputed gold standard for diagnosing a very specific type of female urinary incontinence.
Yeah, it absolutely was.
And today, we're basically going to look at the human body through the lens of pure mechanical engineering. Specifically, we're exploring the female lower urinary tract, it's just an absolute marvel of structural design.
It really is an incredible piece of biology. Structurally speaking, the best way to understand the anatomy is to view it as a hammock. You have this interwoven mesh of tissue, of muscles and fascia sitting right under the bladder and the urethra.
Okay, a hammock. I can picture that.
Right. And its entire job is to just hold everything up in its proper elevated position inside the abdomen. But, just like a real hammock you might have in your backyard, if the ropes start to fray after years of use, or if the anchor points stretch out from bearing too much weight.
The tension is just gone.
Exactly. The tension is lost, and the whole system just sags downward.
And when that biological hammock weakens, the result is a really common but very frustrating mechanical failure called stress urinary incontinence, or SUI.
Right, which is incredibly prevalent.
Yeah. And this is the condition where if you do something like coughing, laughing, sneezing, or even just exercising, it puts this sudden, forceful downward pressure on your internal organs.
Yeah.
And because that hammock has lost its tension, it just can't resist the pressure.
Which results in an involuntary leakage of urine. Because basically the support structure is failing to provide a firm backstop.
A backstop, right.
Yeah, so normally in a healthy system, when you cough, your pelvic floor muscles reflexively contract. That makes the fascial hammock rigid. So when that sudden downward pressure hits the urethra, the tube is compressed tightly closed against that firm backstop.
Oh, I see. So it pinches itself shut against the hammock.
Exactly. But without that rigid support underneath it, the abdominal pressure just pushes the whole urethra down and forces the valve open, which lets fluid escape.
So if a surgeon is tasked with fixing this biological plumbing issue, they first have to figure out exactly how and where that structural support has failed, right? Like before they ever pick up a scalpel.
They have to know exactly what they're fixing.
Right. So our mission today is to explore exactly how clinicians go about diagnosing this mechanical root cause. We're digging into the sources to uncover the clinical purpose of two historic, highly specific, and honestly, hotly debated physical examinations.
The Q-tip test and the Marshall-Marchetti test.
Exactly. Whether you're a medical professional or just someone interested in medical history, or even just like insanely curious about how the human body works, you're going to see how doctors spent 50 years trying to manually measure the integrity of this hammock deep inside a moving body.
And looking at these tests, it's such a perfect window into the evolution of medical knowledge. We really get to see how our clinical understanding shifts when we move from, relying on manual mechanical intuition to actually using precise objective data.
Because sometimes the physical exams that generation after generation of doctors take for granted, well, they might not actually be measuring what we think they're measuring.
Definitely not.
So let's start by unpacking that first major diagnostic tool, which was introduced way back in 1971 by Crissell and his colleagues.
Right, the early 70s.
Yeah. And back then, doctors didn't have high-resolution, real-time internal imaging. They were essentially flying blind, right?
Yeah.
Trying to figure out the geometry of a structural failure. So they developed the Q-tip test. And the main goal here was to measure a condition called urethral hypermobility.
Right, and urethral hypermobility is basically the literal manifestation of that hammock losing its tension.
Okay.
When the support structures fail, the bladder neck and the urethra become hypermobile, meaning they just move way more than they should. They actually drop down and rotate out of the pelvis when abdominal pressure increases.
So to measure exactly how far they're dropping, the clinician takes this sterile, lubricated cotton swab, which is literally just a medical-grade Q-tip.
Literally a Q-tip, yeah.
And they insert it directly into the urethra. They push it in until the tip rests right at the urethrovesical junction, which is the anatomical term for the bladder neck.
Exactly. And by doing that, the clinician is creating this physical extension of the internal urethra that they can actually see protruding outside the body.
Right, so the patient is lying down, And the clinician first measures the resting angle of that protruding Q-tip relative to the floor. Then they do the stress test.
Right. They ask the patient to perform a Valsalva maneuver, which is basically just bearing down forcefully, almost like you're trying to have a bowel movement, or they ask them to give a really hard cough.
And as the patient bears down, all those internal organs shift. The clinician watches that Q-tip move and uses a goniometer, like a specialized medical protractor, to measure the new maximum angle of the stick.
And based on the established literature, if that angle changes by more than 30 degrees from the horizontal resting plane, that officially indicates urethral hypermobility.
To picture this clearly, I like to think of a joystick on a video game controller.
Well, that's a great analogy.
Right. So the swab acts as the stick protruding from the console, and the base of that joystick represents the bladder neck. If that base is mounted in a tight, secure housing, like a healthy pelvic hammock, the stick is barely going to move when you push down on the console.
Right, it stays firm.
But if that base has lost its housing and is all loose, pushing down is going to cause the internal base to drop and rotate, which makes the long end of the joystick, the Q-tip, just pivot wildly upward.
And that pivot is the exact mechanical displacement the clinician is measuring with the protractor.
Yeah.
The larger the upward swing of that stick, the more severe the loss of internal support.
Okay, so we can visualize this joystick swinging upward, but the real question is, why does that specific angle matter so much to a clinician? Why rely on this crazy invasive measurement for decades?
Well, the clinical purpose here hinges entirely on surgical planning. Surgeons really have to differentiate between two completely different causes of stress urinary incontinence before they operate.
Right, because it's not all the same issue.
Exactly. They need to know if the leakage is happening because of urethral hypermobility, which is that loss of structural support we just talked about, or if it's due to a completely separate issue called intrinsic sphincter deficiency, or ISD.
ISD, right.
Yeah, an intrinsic sphincter deficiency is fundamentally a valve problem, not a support problem. You could have a perfectly intact, tight hammock holding the bladder neck exactly where it should be. But if the sphincter muscle itself, the actual valve holding the urine in, is damaged, scarred, or just inherently weak, you're still going to leak under pressure.
So the Q-tip test was designed to draw a line between those two distinct mechanical failures.
Exactly.
Which is super critical because the surgical fixes for a broken hammock versus a broken valve are just completely different. The literature consistently shows that higher Q-tip angles, meaning you have significant hypermobility, are strongly associated with higher surgical success rates for mid-urethral sling procedures.
Right. Those sling surgeries are the gold standard for hypermobility.
Yeah. Doctors basically insert a mesh sling to replace the lost hammock. So if your primary problem is a loose hammock, providing a new artificial one works beautifully. But if your problem is a weak valve, that sling surgery isn't going to fix the underlying issue at all.
And that's why surgeons relied on the Q-tip test to predict those outcomes. If the angle was under 30 degrees, that suggests the hammock is actually stable, which points toward a weak sphincter.
Ah, I see.
Yeah, so then the surgeon would know to pivot to a different treatment, like injecting bulking agents into the urethra to sort of artificially thicken the valve itself.
Okay, I get the clinical utility. I really do. But I have to push back here because inserting a wooden stick into someone's urethra and asking them to forcefully bear down, I mean, that sounds incredibly invasive and painful for the patient.
It is.
Is this really the gold standard? And is it even consistent? Because any test relying on someone bearing down while a stick is inside them just seems ripe for errors.
You're completely right. And the patient experience, along with the test's reliability, are exactly why modern urogynecology has been so fiercely debating whether to keep using it. The sources document the discomfort very clearly.
I can imagine.
Yeah, studies looking at diagnostic methods show patients report significantly higher pain scores on the visual analog scale, the VAS for the Q-tip test, than for pretty much any other evaluation in this field.
Wow.
It's just a deeply uncomfortable, highly invasive intrusion.
And pain aside, the mechanical variables just seem massive.
Yeah.
Because that hammock of muscles isn't like a rigid steel beam, right? It's soft tissue. So how it behaves has to change based on the physical environment at the time of the test.
Oh, absolutely. The physics of the test changed dramatically based on really simple variables. There was research by Yoon and colleagues that proved just how sensitive the Q-tip angle is to the conditions under which it's performed.
What kind of conditions?
Well, they measured the angles in the same patients across different scenarios and found major discrepancies. For example, the angle changes significantly depending on on whether the patient is lying completely flat-like in a supine position versus if they're in a reclining chair tilted at a 30-degree angle.
Because gravity changes the distribution of weight inside the abdomen, right?
Yeah.
Like if you recline, the organs are pushing down on that hammock differently than if you're flat.
Exactly. And on top of that, the angle fluctuates wildly depending on the fluid mechanics of the bladder itself.
Oh, interesting.
Yeah, Yun's team discovered that testing a patient in a reclining position with a completely full bladder actually gave the highest rates of detecting hypermobility because the added weight of the fluid pushes the hammock further down when the patient coughs.
That makes total mechanical sense.
Mhm.
But because the results vary so much based on posture and bladder volume, and because it causes genuine distress, the global medical community is kind of fractured on this now, right?
It really is. We're actually seeing a real transatlantic divide on this.
Right, because the American guidelines, specifically from the American Urological Association and the American College of Obstetricians and Gynecologists, they still list the Q-tip test as a valid tool.
Yeah, the AUA and ACOG still include it.
They add a caveat that it shouldn't be the sole diagnostic factor, but it's still in the toolkit. But then you look at the UK's National Institute for Health and Care Excellence,
Yeah.
the NICE guidelines, and they actively advise against it.
Right.
They explicitly state there's a lack of evidence that performing this painful test actually improves clinical outcomes.
And those UK guidelines really reflect a shift toward minimizing patient harm, especially when the data from the test doesn't definitively change the surgical success rate compared to modern alternative.
Which raises a massive logical question for me. If we know the hammock is dropping and we want to phase out this painful joystick test, why can't a doctor just, look?
Just visually inspect it.
Yeah. During a standard pelvic exam, if the support structure has failed, shouldn't the clinician be able to visually see the vaginal wall bulging downward when the patient coughs?
It's a great question, and clinicians have thoroughly explored visual staging to try and bypass the Q-tip test. They use this highly standardized visual assessment called the Pelvic Organ Prolapse Quantification System.
Which is known as POPQ.
Exactly, POPQ. And when trying to assess urethral support, clinicians focus on one specific marker called point A.
Point A.
Right. This point is located exactly in the midline of the anterior vaginal wall, precisely 3 centimeters inward from the external opening.
Okay, and that specific coordinate is crucial because point A functionally represents the exact location of the urethrovesical junction.
Exactly. It's the visual equivalent of the anatomical landmark the Q-tip is touching on the inside.
So logically, if point A and the Q-tip are tracking the exact same piece of anatomy, a doctor should be able to just watch point A during a cough. If the wall bulges, you have hypermobility. No invasive stick required.
The logic is sound on the surface, for sure, and statistical analyses do show a moderate correlation between the visual descent of point A and the Q-tip angle, but the sources reveal a fascinating catch.
What's the catch?
You absolutely cannot replace the Q-tip test with the visual POPQ exam, because external visual bulging does not always equal internal rotational descent.
Wait, really? If the hammock drops, how could it not create a visual bulge?
Because the tissue layers can actually stretch and mask the internal movement. The research on this is pretty startling. Roughly 29 to 31% of women who visually appear to have perfectly intact support.
Meaning their point A stays high and doesn't visually prolapse.
Right, exactly. They actually possess hidden urethral hypermobility. Their internal structures are rotating and failing, which causes their incontinence, but the vaginal wall isn't bulging enough to see it with the naked eye.
Wow. So nearly a third of patients.
Yeah. If a surgeon relied solely on the visual POPQ, they would completely miss a third of the patients who actually desperately need a surgical sling.
Missing a third of mechanical failures is a massive diagnostic blind spot. So we can't rely solely on visual exams because they hide the internal mechanics.
Yeah.
And we want to move away from the Q-tip test because it's painful and inconsistent.
Right, so we're stuck in the middle.
Exactly. And this is where medical technology finally bridges the gap. The modern solution is to image the mechanics dynamically without invading the urethra at all. Which brings us to transperineal ultrasound, or TPUS.
TPUS has completely revolutionized this specific diagnostic process. Unlike transvaginal ultrasounds, TPUS is entirely non-invasive.
Okay, so how does it work?
The clinician just places the ultrasound probe on the outside of the perineum, and this position provides a really clear, dynamic, real-time digital image of the bladder neck, the urethra, and the pubic symphysis, all while the patient is actively coughing or bearing down.
So the clinician gets to just watch the biological machinery operate under stress in real time.
Yeah.
And they get these precise objective measurements.
Yes.
The sources mention two specific parameters they look for. First is bladder neck descent, or BND, which measures exactly how many millimeters the base drops.
Right, and studies indicate that a descent greater than 11 millimeters, or some stricter studies even say up to 24 millimeters, that clearly confirms hypermobility.
Okay, and the second one is the urethral rotation angle, which is essentially calculating the exact pivot of our hypothetical joystick, but doing it digitally.
Exactly. And a rotation angle greater than 41.56 degrees is highly predictive of stress incontinence.
Wow, that is incredibly specific. 41.56 degrees.
Very specific. And when researchers ran head-to-head comparisons, mashing these digital ultrasound measurements against the traditional Q-tip test angles, the results were incredibly definitive.
How close were they?
They found a correlation coefficient ranging from 0.89 to 0.91.
Oh, wow.
Yeah, in medical statistics, that is an exceptionally strong agreement. The ultrasound captures the exact same mechanical displacement data as the Q-tip, but it completely eliminates the trauma of inserting a stick into a sensitive organ.
The evolution here perfectly mirrors advancements in mechanical engineering. Like, think about taking your car to a mechanic because you suspect a faulty suspension.
Okay.
The Q-tip test is the equivalent of the mechanic walking up to the bumper, shoving their body weight onto the hood, and just visually guessing how much the car bounces. It technically works, but it's crude and relies on a lot of variables. Using transperineal ultrasound is like driving that car onto a modern computerized laser alignment machine.
Yeah.
You get exact objective geometry without having to, manually jump on the bumper.
That's a perfect way to put it. It replaces subjective, operator-dependent physical manipulation with standardized, reproducible digital data.
But, while the Q-tip and the ultrasound are designed to measure how far the anatomical hammock falls out of place, our sources detail a second historic physical exam that takes the exact opposite approach.
Right, because diagnosing the drop is only step one.
Exactly. Surgeons historically wanted physical proof that lifting the tissue back up would actually cure the patient before they committed to a major operation.
Naturally.
And this desire for a surgical preview led to a completely different, highly debated physical maneuver, the Marshall-Marchetti test.
The Marshall-Marchetti test, and there's also a very closely related one called the Bonney test, they represent this fascinating era of surgical intuition. It was quite literally an attempt to simulate the mechanical results of a bladder suspension surgery right there in the exam room.
Okay, so the setup for this simulation is very physical.
Huh.
First, the clinician fills the patient's bladder with fluid to ensure the system is, under load.
Right.
Then they ask the patient to cough, and they actively observe for urinary leakage. This first step basically establishes the baseline, proving that under abdominal stress, the valve fails and urine escapes.
Right, you have to prove the leak exists first. And once that baseline leak is confirmed, the clinician performs the simulation. They place two fingers, or in some variations, they use an instrument called an open Alice clamp inside the vagina.
Okay.
And they use their fingers to manually elevate the tissues surrounding the bladder neck. They are physically pushing the anterior vaginal wall and the urethra back up, lifting them into their normal, elevated retropubic position.
So the clinician's fingers are basically acting as a temporary human hammock, restoring the structural tension that the patient's body lost.
Exactly. And holding those tissues firmly elevated, the clinician asks the patient to cough forcefully one more time.
The clinical logic here seems, incredibly straightforward.
Yeah.
Like if the patient coughs while the clinician is holding the tissue up and the urinary leakage completely stops, the test is deemed positive.
Right, a positive test.
And a positive Marshall-Marchetti test historically served a massive clinical purpose. It was interpreted as definitive proof that the patient's incontinence was strictly due to a loss of anatomic support.
Because you lifted the support and the leak stopped.
Exactly. And more importantly, it acted as a physical preview, predicting that a surgical bladder suspension procedure like the Marshall-Marchetti Krantz operation or a Birch-Culpo suspension would successfully cure the patient's leaks.
Because in those surgeries, they permanently suture those tissues up into that elevated position. So it provided surgeons with immense confidence. They could physically see the leak stop, so they believed the surgery would replicate that exact mechanical fix.
Okay, but I have to apply some basic fluid dynamics logic here, because this beautifully simple mechanical preview seems a little too good to be true.
Oh, you're onto something.
Right. Let's say I have a leaky rubber garden hose in my yard. If I jam my fingers into the mud surrounding the hose and pull upward with force, am I actually restoring the proper structural alignment of the hose?
Mm.
Or am I just accidentally pinching the rubber tube closed with the pressure of my fingers?
Ah.
Because either action will stop the water from leaking.
And that deduction points to the exact fatal flaw of the Marshall-Marchetti test. For decades, surgeons believed they were relining the hose, but they were actually just pinching it shut.
Wow.
Yeah, and the definitive proof of this came from a pivotal urodynamic appraisal conducted by researchers Bergman and Bhatia. They realized that visual observation just wasn't enough. They needed to understand the internal physics of what the clinician's fingers were actually doing to the urethra.
And to measure that, they couldn't just look for leaks on the outside. They had to measure the internal pressure of the valve itself during the manual elevation, right?
Exactly. They utilized specialized pressure catheters, threading these tiny sensors directly inside the urethra.
Oh, wow.
Yeah, and these catheters measure the internal closure profiles, which basically records exactly how much pressure is being exerted on the walls of the tube from the inside out. They monitored these pressure ratings continuously while the Marshall-Marchetti test was being performed.
And what those internal pressure sensors revealed completely dismantled the foundation of the test, didn't it?
Completely. The urodynamic data proved that the manual elevation of the tissues by the clinician's fingers was actually occluding the urethra.
Occluding meaning pinching shut.
Right. The fingers were creating immense localized pressure that simply squeezed the urethrovesical junction completely closed.
So the test restored continence during the course, not by properly restoring the hammock's natural tension, but by simply clamming the tube closed from the outside.
Exactly. The internal pressure profiles recorded during the manual elevation were virtually identical to the pressure spikes recorded when the researchers intentionally clamped the urethra shut.
This means the test was generating massive false positives.
Huge false positives.
Because if you pinch a fluid-filled tube, it's going to stop leaking regardless of what the underlying problem is. It'll stop leaking if the hammock is broken, and it'll also stop leaking if the internal valve, the sphincter, is totally damaged.
Right. It masked intrinsic sphincter deficiency entirely. Because manual compression stops all leaks, a surgeon might perform a major abdominal suspension surgery based on this positive test, operating under the assumption they're fixing a support issue.
But then post-surgery.
Post-surgery, when the mechanical pinch of the fingers is gone and the tissues are just sutured in place, the patient continues to leak. Because their underlying issue was a weak valve the whole time, and the suspension surgery doesn't address the valve.
Oh, man.
Yeah, this discovery fundamentally invalidated the Marshall-Marchetti test as an accurate prognostic tool.
You know, when you look at this entire evolution, from the Q-tip to the ultrasound, and from the Marshall-Marchetti test to these internal pressure catheters, it really highlights a massive shift in how we approach the human body.
It really does.
It is so easy to fall victim to clinical intuition. The thought process of lift the tissue up, the leak stops, therefore lifting it surgically will cure it, is incredibly seductive logic.
It makes perfect sense on the surface.
Right, but it completely falls apart once you actually measure the internal physics of the action.
And that transition away from these historic physical exams underscores the vital importance of objective technological measurement in medicine. Clinical intuition and hands-on physical exams are, the bedrock of diagnosing patients, but they have profound limits when dealing with complex internal forces.
For sure.
Moving toward multi-channel urodynamics and transperineal ultrasound represents a really necessary evolution. We're moving from subjective physical manipulation, which can easily mislead us, to objective physiological science.
Well, we've unpacked the mechanical ingenuity, the original clinical purpose, and the deeply hidden flaws of both the Q-tip and Marshall-Marchetti tests today. They represent a critical chapter in our quest to understand the complex hammock of pelvic support.
They absolutely do.
And they perfectly illustrate why the field of urogynecology is rapidly abandoning painful, variable physical maneuvers in favor of highly accurate, non-invasive imaging technologies to assess stress urinary incontinence.
It serves as a powerful reminder that our knowledge base is strongest when we continually test and question our own assumptions. A physical examination that was taught as standard practice in medical schools for decades can be entirely reevaluated when new technology allows us to see the underlying mechanism. Blending multiple perspectives from the practical realities of the exam room to the hard physics of the urodynamic laboratory is how we truly advance our understanding of human biology.
The value of relentlessly questioning established medical dogma really cannot be overstated because the science of the human body is always being refined. Which leaves us with a final, provocative thought for you to mull over.
Yeah.
We just detailed how a physical examination as universally established as the Marshall-Marchetti test was historically giving surgeons the right answer, stopping the leak, but for completely the wrong mechanical reason, by pinching the tube instead of supporting it.
Right.
So how many other everyday physical tests in modern medicine, the simple maneuvers we take for granted when a doctor examines us, are actually working through mechanisms we don't fully comprehend yet? The human body is a masterpiece of engineering, but it's clear we are still learning how to accurately read the blueprints.